So, Dr. Suresh Pandey is our last speaker, and Dr. Suresh Pandey is the Editor General of Rajasthan Ophthalmic Society. He's trained from PGI Chandigarh. He has done fellowship from US under Dr. David Apple, and he has numerous international publications, and is currently the director of Suvi Eye Institute and LASIK Center at Kota, a brilliant surgeon. Dr. Suresh Pandey, over to you.
Thank you, Dr. Harsul and Dr. Chitra ma'am, for making part of this excellent ARC webinar. Today, I'm going to share an important technique which is already published by some of the panelists, Dr. Rohit Om Prakash in the JCRS 2017 issue. And this technique is the pre-IOL implantation, pre-phaco implantation, or IOL scope folding technique in case of mature, hypermature, and Morgaginian cataract. We all know that after lockdown, we are seeing a lot of cases like this, mature, hypermature calcified cataract with a lot of intralenticular fluid. And once you get such cases, it's very difficult to manage such cases. And there are a lot of high risk of complications such as Argentinian flex sign and floppy posterior capsule, weak jonules, etc. So the pre-phaco IOL implantation or IOL scaffolding technique in cases of intact posterior capsule can one of the most important tool to manage such cases. In this case, you can see the protrusion of the nucleus from the capsular bag after achieving capsular axis. And once you protrude the capsular nucleus from the bag, make sure that you fill the capsular bag with the viscoelastic so that the capsular bag is fairly distended. Viscoelastic will act as a third hand, and this is the multifocal IOL implantation done in the capsular bag gently. And once the lens is implanted in the capsular bag, then we just manage the phacoemulsification of the hard cataract in the iris plane or somewhat in the anterior chamber plane. And it's very important to coat the endothelium by using viscoelastic such as chondroitin sulfate OVD to minimize the endothelial cell loss. And here, make sure that you remain gentle and to avoid the damage to the IOL. And here you can see the well-centered multifocal IOL in a case of hypermature calcified cataract, and the patient achieved excellent vision. This is the second case, hypermature cataract with the lot of cortical milk. So anterior capsule staining is very important tool in such cases, and I always prefer to stain the anterior capsule under an air bubble. You can use the ultimate soft cell technique described by Arsenov, and this is the phacoaxis or punchoaxis, what is labeled by Dr. Mohan Rajan. And in you can try phacoaxis, or you can use japtoaxis, and make sure that you aspirate the cortical milk. It's very important to aspirate the cortical milk to ensure the good visibility of the capsule flap. And we always try to aim for the 5 mm axis. And here once again we are just trying to protrude the tilt the nucleus, and then you just implant the one-piece lens into the capsular bag after distension of the capsular bag using viscoelastic. And once the capsular bag is, once the lens is implanted, you can use the sharp chopper, or you can use blunt chopper. I'm using Dr. Mohan Rajan's sharp chopper to do vertical chop in this case. And notice that the cataract is removed nicely without much complication and much phaco power. And it's very important to use or to coat the endothelium with the chondroitin sulfate-based viscoelastic to ensure there should be minimal endothelial cell loss. And always avoid this technique in the shallow anterior chamber or nanophthalmos or small anterior chamber, small axial length cases. So make sure that you do endothelial cell count, and always avoid in cases of small eyes or shallow anterior chamber. This technique, IOL scaffold assisted phaco, can be very helpful technique to manage the white mature Morgaginian hypermature cataract, especially which are not uncommon during post-COVID lockdown time. Thank you.
Thank you. Thank you very much, Dr. Suresh. Very valuable input you gave. I just wanted to know that would you always suggest placing the haptic of the IOS scaffold on iris, or if you can visualize, you would put it in the sulcus?
Ma'am, in this case, in both cases, I put the haptics in the capsular bag.
Okay, in the capsule.
In both cases,
It was in the bag only, I think.
yeah, it was in the bag.
You have to put it on the iris only if you have a PCR in place, where your
Yes.
IOS stability is in
Yes.
doubt.
Can you, once
Yes.
you put it on,
Put it in the bag.
once there is a scaffold there and you're collapsing the nucleus out, do you think you will cause a little more endothelial damage as compared to the phaco that you would do absolutely in the back?
Actually, once you put the lens in the capsular bag, you know, the nucleus is little away. It's in the iris plane, so there can be a little more trauma to the endothelium. But you can overcome this trauma by frequent coating of the endothelium with the viscoelastics such as chondroitin sulfate based OVD.
I have two questions for you, Suresh.
Sure.
One is this hard brown cataract, as Amrita said, you are bringing it anteriorly, iris plane, and sometimes you're closer to the endothelium than what you are normally. Second thing is the phaco energy. What is this thing that phaco energy cannot damage the IOL?
IOL, exactly. Yeah,
Yes. Yeah. This is very.
IOL, you don't know what micro damage is occurring to those.
Yes, yes, that's very valid question.
Lens, no?
That's very valid question, Dr. Mohan. First of all, I'm using your sharp chopper, Dr. Mohan Rajan sharp chopper. You can, you know, even kill the any patient, you know, with the sharp chopper. Yeah. and you know, you can emulsify any dense cataract. You know, it's very easy once you have your chopper in hand. And
but you can chop nucleus lens also, no?
Yeah, yes. Concerning the damage to the IOL, you know, rings, multifocal IOL rings, this is valid concern. But what we can do, you can just be careful and use viscoelastic cushion. Use dispersive viscoelastic as a bolus, and that bolus will work as a, you know, some sort of coat the protect the IOL.
Actually, I think in defense of Dr. Suresh, I'm just saying that, you know, usually this is Gagnian cataracts where the nucleus is really small. It may be hard, but it's really small. But definitely, if there's a shallow chamber and a thick nucleus, then it's not a great idea because the space will be very little and endothelial compromise will be much more. Yes. But I think if you reserve it for these small nuclei which are going to run around and, you know, be mobile, and there's almost no cortical support for the capsule, it's a great technique, and I think even I've used it a couple of cases.
Yeah.
I think basically this technique which I published in JCRS was basically for the last nuclear fragments, because, you know, in Morgagnian cataracts there are 3-4 things which are happening. Yes, first, you're using high fluidics. And the second, there is some bit of capsular weakness. The vitreous at that point of time is at times fluidic, so there is fluttering. To prevent that fluttering, you can put the lens. But you know, the problem which we usually face in these Morgagnian cataracts is that we have difficulty in immobilizing the nucleus because the nucleus is mobile. In that situation, what you can do is you can immobilize it by taking the equatorial support of the opposite side. So you push it slightly, you have the equatorial support, and then you chop it. And once you have the last nuclear piece left, you can do. The advantage of using this scaffold is that you can work at a deeper plane and with the visco around. But definitely I have some reservations if we have to use it as a full, you know, the whole nucleus piece coming, the whole nucleus coming up, and, you know, and the shallow chamber, as Dr. Gaurav said. So you can, you know, immobilize it, divide it, and last nuclear pieces you can use it.
That's very good point, Dr. Rohit. I think I had read your beautiful paper in the Jan 2017 JCRS issue. And in this case, which I have shown, I have used because this was a myopic eye, 26.18 millimeter axial length, and, you know, deep entry chamber, and the IOL power I put was for 12 diopter.
Perfect. Yeah.
Thank you.
Fine.
Any other questions, Harsha?
Yeah, I think we are well in time.
Yes.
We have 10 minutes for discussion. If there are any other questions, we can take those questions, ma'am.
I would suggest for Morgagnian cataracts, no?
Yeah.
Can I?
Sir.
Morgarian cataracts, what you do is go bevel down, go to the
That's
center of the nucleus. Okay, it is called phaco boring technique, where you can go center, bore it nicely, and then you can chop from the periphery. That is because the cataracts are very, very small. That is, the nucleus is very small. The overall diameter is very small. Go to the center and catch it nicely, and then use a sharp chopper, and then you can chop it easily from the periphery.
Yeah.
Only thing is, bringing it to the anterior chamber, I'm a little skeptical about it.
So in fact, you don't need a sharp chopper because, you know, posterior capsule is very much open there and exposed there. You just need a chopper to get it from equator of the lens. It cracks it easily. Yeah.
Actually, Dr. Rohit Prakash's technique works very well, where he takes the support of the equator and to stabilize the nucleus and then crack it, because, you know, otherwise all the other techniques will either bring it up or you'll have a sharp chopper which can damage the PC. So I think what Dr. Rohit explained and what he's published is fantastic.
Yes.
Do we have anything else, or shall we conclude?
Ma'am, I was wondering about that Pancho Rexus, and it's really scary for me. And it's very uncontrolled, frankly. Dr. Mohan said beautifully, but everybody else, you know, I think the Pancho Rexus.
No.
I think
for a learning curve, you have to do it properly.
You don't want to learn.
HPMC, don't use Hyalon, don't use Viscoat, go bevel down, go vertically down, and go all the way down on your phaco foot stitch. One burst of phaco. If you go halfway through, then you will end up in Argentina fracture.
No Kelman tip. That is another important
No
thing.
Kelman tip.
And
Straight tip, either 0 degree or a 15 degree.
No ozil for that.
No ozil. Straight longitudinal phaco, straight continuous phaco power, keep it around 50% and keep the vacuum around 350. I usually use a stellar machine for that. Whatever machine you're comfortable, yeah, that's fine. Just one punch.
Do you always get a round punch in the anterior capsule with this, or the edges are regular?
Get round punch, but you'll get something like this, like a pure.
Yeah.
But after that, you can make it 5, 6, whatever size you want. 200% it will not go to the periphery.
So I think I'm going to conclude now. Before our speakers leave, I need to thank them. It's been a truly amazing couple of hours with so many tips and learning in cataract surgery. I think it's not just for the speakers, it's been for every one of us. And my very special thanks, or rather our special thanks from ARC to our ever strong expert panel. Very impressive set of speakers who took so much interest in giving something new and novel in this webinar. Thank you, everybody. Our thanks, of course, are due to the AIOS admin team under Mr. Kripal, who have been very helpful at all times. Our webinar admin, Mr. Sunil, who's also been always a constant support and help. Sai and Manjula from Numerotech. Please do wait on speakers. You would get your link so that you could hear how well you spoke to us today. Our dear sponsors from Entode Pharma, who have been a great support for every venture of ARC. And our thanks are due to all the attendees who have been with us. And you know, that itself is a huge source of encouragement. Thank you, one and all of you.